Well, hello, everyone. I'd like to welcome you to our fourth digital health webinar session in our digital health webinar series, sponsored by the College of Health Sciences and the Health Sciences Entrepreneurs Program at Northeastern University. I'm Laurie Bishop. I am the program manager for the Health Sciences Entrepreneurs Program here. This is my advertisement. And we're pleased to be putting on these sessions to be able to bring experts together to really dive deep into digital health and wellness and the trends and all of the things to take into consideration in the digital health space. Tonight, where our focus is on data and the importance of using data in digital health. We have Nirban Singh Bhatia, who will be our moderator. He's a third-year student at Northeastern, and he will be leading our discussion with, he will be guiding our discussion with Rhonda Manns, who we're really happy to have here. I'm going to hand it over to Nirban to introduce Rhonda and get our program started.
Awesome, thank you, Laurie. We're going to actually start with Rhonda talking a little bit about her journey because her career path hasn't been the most linear. She might have a bunch of these credentials, but I think if she can, dive a little bit into her background and, where she's gone and how she's gotten where she is, I think that'd be a great way to kick it off.
Thanks, Nirban, and hello, everybody. So I'm Rhonda Manns. I've been a nurse for about 12 years now. Time flies when you're having fun. I started my first nursing journey in acute inpatient rehab, dealing with patients who had brain injuries and strokes. Transitioned into ER nursing, which I loved a lot. I think it was the fast pace, it was the variety. And that was actually, it was the time when you see people usually at their most worst and they're vulnerable. I have spent some time in biopharmaceuticals. I worked with rare disease patients, pulmonary arterial hypertension, idiopathic pulmonary fibrosis, and some rare blood disorders, which were really interesting. Hemophilia may be one that someone might be familiar with. Also, hereditary angioedema is another one of the rare ones, which we may cover some rare disease information during this seminar here. Shortly after that, I became a little restless in my career, and rather than getting my MSN, I decided I wanted to be a clinical thought leader who could both speak to the clinician as well as business systems to form that linkage so that we can increase quality care and patient care delivery. So that meant that I went back into ER nurse management, where I spent some years. I transitioned into health IT, doing some training sessions with Epic Systems around the nation, which was really, really interesting and quite fun as well. And then my career transitioned into case management, where I particularly help members post-surgical and just throughout the transitions of care through the health systems. I also did a lot with disease management, which allowed me to get a lot of really cool experience with deploying a lot of different teaching techniques and really getting into the nitty gritty about how do we increase quality care for all members, right? But here recently, I was able to switch into a senior capabilities analyst role, which essentially is a senior business analyst. I work with a phenomenal software development team where we create clinical innovative products every day. Pretty much we work on digital health, we work for population health, we deal with a lot of Medicare population. And shortly after spending some time there, I was able to obtain a new position at my current place of employment as a product owner. So whereas my previous role was focused on gathering the business requirements to deliver to the software team, now I'm focused on the delivery of that software feature or product back to the business so that the business can do its best work. So aside from being a nurse, I am also a member of SONCIO, which is a society of nurse scientists, innovators, entrepreneurs, and leaders. It was started, and the president is Rebecca Love, who is an alumni here of Southeastern University Entrepreneurship School. So really, really excited. To Nirvan's point, my career hasn't been linear, but I'm at a place now where I can see all of it kind of networked and meshed together for a good purpose. So I'm glad to be here and share those experiences.
Great. Yeah, thank you for that. I think that gives us pretty good idea of how you bounce around, and especially, you're passionate about, patient care and making sure that patient care is delivered at the highest of quality, especially with a focus on, healthcare outcomes as well. So let's just dive right in, and let's talk about health data. So why don't we begin with you giving us a little bit of an overview of the greatest sources of health data, and giving us a little bit of insight into how data plays a role in understanding patients and providing them with better care.
Okay, great. So when we talk about data sources, there are a few major sources and maybe some ancillaries as well. So the first I would say would be inpatient and outpatient medical records, pharmacy, claims, and data. You also have a lot of data coming in from insurance claims, as well as, the lab, right? We're talking about point of care testing today. So we'll also be focusing on some lab data as well. But to get more into your question, the way we think about data, if you just take a hospital in itself, right? A hospital is a building, but it contains a lot of different clinical systems. I was just speaking with a former colleague of mine. She works for a health system that uses over 200 different clinical applications. And I guarantee you that less than maybe 25% of them actually speak to each other. And that's what's called as interfacing. So why is this important? We have data that comes from different sources, including wearables and non-clinical data, some consumer data. But when you have a patient who enters into the health system, it's very, very important that providers can see reliable and verifiable data at the point of care, like at that time. So case in point, you look at the ER, you need a real-time and accurate info. If a patient should present to an ER and they're walking, we call them walkie-talkies, right? They're walking, they're able to speak and provide medical data, that's fine. That's not a barrier. There's really no big challenge to that. But when you consider the patient who may come in as a trauma patient, or someone who's intubated or disoriented, or they've had a medical event, they can't speak for themselves, or maybe they're just what we call altered mental status, that maybe their sugar's too low, it's too high, or something like that. They can't provide data. We need to be able to access that medical data immediately. What's the past medical history? What are we looking at? What's this cause, right? What allergies do they have? Because most likely the doctor's going to provide an intervention to correct what it is that he sees. Without understanding the allergies, that can go really wrong, And then in addition, when you talk about like medical care inside and outside of the hospital, there's some medicines, there's some conditions that require very specific medications. You look at our ESRD or our end-stage renal disease kidney patients, it's a challenge to really manage their health condition well because of all the different changes going on with their labs and such. Or if we even look at people who may have blood clots, right? You're prescribed a medication that requires a lot of monitoring, and that involves data, interpretation, and retrieval. So.
Yeah, that sounds like a lot of data. And data that's definitely critical to every point. I mean, as you mentioned, even the slightest of things that, we might not find important, like allergies, can play such a huge role in, eventual diagnosis and, again, the eventual health outcome of that patient. So with all this data, there has to be some sort of requirement or an emphasis on consistency and protection. So can you explain, this concept of data integrity and how to maintain that in a clinical environment?
Yeah, sure. So let's first start by defining what data integrity is. Data integrity is having accurate and complete medical record. So as we interact with the electronic health data and it's gathered from different sources, we need to be able to match the data with the patient. And that becomes a challenge because, and I'll give you an example. If Rhonda goes to her doctor's office, right, and they use a software that only takes in my first name and my middle name, my first name and my last name, right, there's an encounter, there's a record that exists for Rhonda Manns. But if I go to the ER and they use a software that takes my first name, my middle name, and my last name, eventually what the health system is going to have to do through a process called patient identity management is try to identify, match both those records and confirm that this is in fact the same person. This is important because there could be some episodes of care that's happened over here that the ER doctor can't see over here. And you also have to be able to verify that, yeah, you might have a Jane Smith, which is actually a common name, and another Jane Smith, but at what level is it that we can actually truly believe that this is, both records belong to the same person? So that's that. So the challenge is, how do you track and combine medical records for the right person? What's the threshold that you use? And what's, what types of processes inside your hospital exist so that the data is actually verifiable, I think.
Got it. Yeah. So that sounds like, to make sure that infrastructure exists, there has to be definitely some sort of investment from leadership, and those leaders that actually use the data, who recognize the importance of, that connection across the system itself or multiple systems.
Sure. And to your point, I think it's really important that as we have conversations with healthcare leaders, that we really emphasize why it's important. I think sometimes when we deal with technology, we think at the price tag, but we have to explain what value is added, right? So back to your point about protection, how do we protect patient records? And then how do we ensure that the data is complete? So you on the call may or may not be familiar with HIPAA. HIPAA is a federal regulation, like to break it down really small. It's a federal regulatory mandate that talks about how patient data is held, contained, and revealed. That in itself, it's got its pros, it's got its cons, it has its challenges, it has its benefits. But then you also have to know that on a state level, states also have a privacy level about how data is going to be transported in their state, how things are going to be disclosed, and what types of things will be disclosed. So in the case of special circumstances like maybe HIV or AIDS or certain communicable diseases, there might be higher restrictions on that. Even, I didn't know if you knew this, Nirban, but pregnancy status is also a special protected status as well. So you have all these things in play. You have all these different key players. Some may restrict access, some may say go, some may say stop. But I think in terms of securing the data, you have to look at what rules exist. And then on a technical aspect, the 3 top ways that you can handle data. You can either remove the identifiers from the person, which is oftentimes the case in clinical trials. You can encrypt the data, which means to take the data and kind of transform it into something else, whereby the person who has the key is the only one to open it. And then there's this really cool thing called pseudonymization, which means it's like the combination of both. And essentially what happens is it removes the identifier, like the identification on one level, and then it also kind of transforms the data in a way that can only be read by the party. What's really cool about that is it's actually reversible, unlike some of the others that I mentioned.
Wow, yeah, I did not know about the pregnancy status piece, but that's really cool. So I guess data's at every step of the way. And I guess you talked a little bit about the importance of investing in data. And now we see the surge in healthcare. The whole industry is going towards harnessing more of this interoperability. So do you mind explaining what that even means, and how you've seen interoperability take over in healthcare at this point?
Sure. So to define interoperability, I think the best way is to say is just, how do we link together patient information from various sources in a way that's actually usable for the end user? So we have that fundamental use, and then we also have some benefits, some pros, some cons, but we have some benefits to why this may be good. So remember how I said there's a lot of different data sources all about, out and about? So in the case where a person may go to the doctor's office and then the ER, that individual may also visit a community clinic or a pharmacy. So what we have to do is interoperability is really, how do all the software applications speak to each other to present that data for the doctor, so that the doctor or the clinician or the nurse or even the nurse practitioner can take action on that to help the patient. And so why is this important? Data has to be collected, it has to be secured, it has to be mapped, it has to be cleaned, right? It has to be stored, it has to be secured. Like there's a lot of different things in play for it. And so this is why we see the tension between technical requirements, ethical use of data, and then also operational use. And at any given point, similar to how HIPAA is federal and state level may conflict, you might see that. You very definitely may see that. But what it comes down to is that interoperability, the best part of interoperability is to be able to provide that access back to the healthcare provider at a level that's actually useful. So my medical doctor in the office, she may need to see that I've gone to the ER and I've been to the community clinic and I've picked up my prescriptions. But maybe if I go to a community clinic for a vaccine, they may not need my whole record, which in itself lends to some opportunities, I think though, like just to solve it all for you, like to end it, the increase of operability, like the fact that we need, like this is very important and we need to do this very well, actually creates a new business model for entrepreneurs who want to come and help solve health problems. So for y'all out there who are trying to deal with medical devices or just trying to create new innovative ways, definitely think about that. Interoperability is key and it could actually make or break your device or your product, your service.
Wow, yeah, that is definitely something, like for example, for myself, I mean, I haven't really seen it as much. I've heard about it, and I think I've heard about it broken down in different ways, even in textbooks sometimes. But I think, it's a lot to wrap your head around just because of each of the components that need to work very smoothly in conjunction so that there aren't any hitches in the data processing process. So, I mean, with interoperability, there seems to be a lot of potential, but can you talk about some of the pros and cons and sort of weigh those out?
Yeah. Pros and cons. So interoperability. So where I've seen interoperability done well has been with the creation of the EMR. When I mean EMR, that could be it stands for the electronic medical record. To some degree, we have some sort of exchange of information between a software platform and maybe a secondary vendor. So in the case of the hospital, you think about the hospital and all the different departments that it has. Just because you're in the ER and you get lab samples taken, that needs to go over to the lab, where the lab has its own software and its own documentation. And then you need to interface between there. And then that needs to be sent off to something else, right? Maybe billing and reimbursement. So the pros of interoperability is that the more links that we can connect, the better it's going to be for patients to receive great care, because we want to be able to see the patient's life in a longitudinal way. We don't just want to see, like for you and I, we know each other here, but maybe somebody knows me as a sister, or maybe somebody else knows me as a daughter, or someone knows me as an employer. So what you need like that rounded view of the patient so that you can do the very best at that point of care. Cons, EMRs aren't here to save the world. There's many different vendors, you might have the top 3 or 4, but they may reside in the hospital system. You will also see that about 72% of the physicians' offices, because of the Meaningful Use Act that came out a few years ago, they have their own individual EMR records, which is great because when you see them, they can chart in real time and do all the things that they need, but their system may not be visible to one of the large vendors because of cost, price, availability, interfacing, and things like that. So that's just a little bit about pros and cons.
Great, thank you. I think, that definitely interoperability seems like something to keep an eye on, especially as we start to have this processing power to take on more and more data. I think with, technologies coming from more of the tech world, meshing in with, some of our more clinical situations. I think that's definitely an interesting one. So I guess for now, we can take a quick pause and we can ask for any questions out there about anything that Rhonda just went through, or anything even tangentially related to what we've been talking to so far. And, as Lori just put in the chat, you can type something up, send a message to me, or even just unmute and speak up, and we'll probably move on to the next section in about the next 3 to 5 minutes.
This is Martina. I have a quick question about, hi Rhonda, we know each other, about different systems at different provider offices, because I used to work in a similar space, also directing the development of software platform. And from my experience, it's not uncommon for a provider office to have multiple softwares that don't talk to each other. And sometimes it's actually overwhelming and surprisingly overwhelming amount, like let's say 10 different softwares or 12 different softwares. And some of them look like programs that were developed, let's say 10, 20 years ago, and they don't necessarily talk to each other, but this is how it was historically set up. And it's not completely trivial to replace them. So do you have any thoughts on all these systems, and also from your experience, like how typical is it that office may have like 12 systems that don't talk to each other?
Yeah, so that's a great point, Martina. It's great to see you on the call. You're absolutely right. I mean, and this kind of leads a little bit into what I wanted to bring forward about clinician burnout. But when you think about going to a doctor's office, you're right. Sometimes they have to open up 3, 4, 5 different applications just to be able to prepare themselves to either review the chart or interact with their patient. What I would hope would happen is as we continue to increase interoperability, which I think we're seeing some good progress. HL7 is a standard in which documentation has to happen. And so what we're seeing is that when people are developing digital health products, they're actually trying to develop it in a way that enhances and already kind of abides by the interoperability rule. So rather than developing this really cool thing in the out space, I think entrepreneurs are definitely thinking, okay, how do I develop a product that is just plug and play? Right? We don't want to develop the next EMR, but we want to make this widget maybe that fits into the EMR. So I'm hopeful. I think the future will definitely bring some more closure, because with every separate system, what you'll see is you'll see gaps. You see the risk for not being able to take care of the patient that you need to. And you also see a gap in knowledge, data, and continuity. I think continuity is going to be really key in the next, year or two, especially given the pandemic.
Yeah, thank you for that question, Martina. Seems like we're getting a couple questions in the chat. So I'm just gonna take the first one, and then Carmen, feel free to ask at the end of the session. So Emily Silvestri put a question in the chat saying, how would you address those who don't want something shared with other medical providers, such as mental health records? As interoperability increases, providers will be able to see everything to make a good and accurate diagnosis. But what about the information people don't want to be shared? Do doctors need to see it? And can people choose?
Great question. Emily is bringing her A game today, and it's good to see you here as well, Emily. So here's what I want to say about that. There's general rules about data sharing and medical information. And then there are also like special extra provisions on things that are sensitive, like mental health, some sort of, I'm thinking of like the best way to say this, but mental health, or if someone is recovering from some sort of drug use or recovery and things of that nature. To kind of get down to the nitty-gritty of your question, I don't really know how a patient, I think this is a challenge. I think this needs to have a solution. I don't know how you can truly engage with a doctor in a way that verbalizes their needs, but doesn't end up in the chart, right? Because it's important that it's in the chart, but also there's that level of dignity that we have to, we have to protect. And I'm struggling to answer this question because I see it from both sides. I see it from the nurse who, I'm going to ask you very blunt questions. I'm going to ask you very focused questions respectfully. I'm going to really dig down deep and say, why are you here today? Are you struggling with anxiety, depression? Are you, maybe using or misusing any prescriptions for you? But at the same time, I have a heart of a patient where I've gone into situations having to disclose things to doctors, and then there's that hesitancy of, well, how much do I tell? So when it comes to data and data use and data sharing, I do believe that, and I'm not incredibly skilled in this area, but there is a level of protection for certain classifications of medicine. Of visits, certain classes of data. I'm thinking also about the CARES Act, which was recently released this last year. And for those who don't know what the CARES Act is, the CARES Act pretty much says that a patient is given their data at the point of care. So sometimes you can be in the ER, you can go have a CAT scan, come back. When the results are ready, those results are actually delivered to the patient real time, which is good or bad, right? If you're the patient and you want full transparency of your record, that's great. You want to have it so that you can take it and kind of take it with you. But at the same time, if there's something kind of, scary or sketchy, or there's terms that you don't really understand, and you start to Google something, it can create panic before your doctor has an opportunity to come in and say, hey, listen, you may have an infection, or we found something. So, that was a really long way around going to it, Emily. I don't really know. I don't really have a full answer for you, but I hope that my questions has kind of led you to maybe, I don't know, more questions. I don't know that it's really helpful, but but yeah, Emily, thank you for that. That's something that I should maybe take up and maybe carry on as well.
Thank you so much.
Thanks.
Great. Those are some great questions. There were a couple more in the chat, but again, we'll get back to those at the end of the session. So let's move on and let's talk a little bit about the challenges of using data at the point of care. So
Yes.
You've touched upon this, and you have some of the best experiences in this space, and I think a lot of our guests here as well are very interested in learning more about this. So to kick it off, what are some of the challenges with implementing data-driven solutions at the point of care?
All right. So here's what we got to think about. We have to define what point of care testing is. And point of care really existed to help to facilitate the lab system. So point of care is any kind of device that's handheld, portable, that can help to contribute to a doctor's knowledge for the purpose of diagnosis or as a preliminary analysis tool. So we're all very much familiar with glucometers. I may just use that going forward as an example. But the purpose of point of care is really to provide immediate results. So in an ER, labs, their turnaround time is about an hour. But in the community, if you go and visit your doctor, it may take 24 to 48 hours or maybe even 3 days for you to get those results. So the purpose of point of care, when we establish just what the point of purpose of point of care is to give that immediate results. So what's your challenge? Anytime you have a device, whether it's a cell phone or anything else, you have IT security concerns. This is a device that's literally collecting patient data and it's storing it, right? Then you have to transmit that data through either a docking station or maybe a wireless access point. Inside the hospital, if you have many different healthcare providers using a glucometer, going room to room to try to, obtain blood sugars, you have to determine user access control. Who has the right to use the machine? You have to make sure there's quality control. Is it being checked for accuracy, like the glucometers twice a day? Is it providing accurate results? Because that's important too. Not just results, but accurate results. There are medical, Carmen's mentioned, I think in the chat, she's a critical care nurse. So of course, I know she's familiar with Coumadin or warfarin sodium and also heparin. A lot of these medications require very tight monitoring and frequent blood draws. Heparin, every day, which, just on a side note, the point of care testing now in the home for people to monitor their Coumadin levels has been a complete blessing for people who used to have to go to a clinic every week or maybe every day on the onset of their medication. So there's that. Challenges, linking it to a system. Just because my fancy device gives me some numbers, what's going to happen now? It has to be able to transmit that data through middleware, which is software, between the device and the laboratory system, because the data needs to go somewhere. Someone has to receive it. Someone has to do something about it. And so that brings up a whole list of other, issues. access control and things like that. Specifically in the hospital, you have to think about this. How are your users going to access this point of care device? Will they use a PIN? I know I have an iPhone. I can put it to my face and it will read my face and unlock it. In the hospital, that may not work. We're wearing masks, we have PPE. Fingerprinting is not going to work. If I've got gloves on, I'm not putting my fingerprint on on a sensor that's going to actually work. So you have to determine all these different things about point of care testing. But for the most part, those are the high level, like the biggies.
Yeah, so it seems like everything is very intertwined. And it seems like there are a lot of little things like you just mentioned with the fingerprint or, the face scan that we, even overlook just because we're trying to solve a bigger problem. But, it's the little things that do make a big difference. So I guess piggybacking off of that, do you mind touching on how some of these technologies might impact provider workflows?
Sure. So anytime that you add a device into a healthcare environment, you've got to know that it's going to impact the workflow tremendously. And it's not at a scale of 1 to 1. It's like 1 and exponential, right? When technology works, so when a device works and it comes along to make your life easier, when it works well, everything is great. But when it doesn't work, what happens is it leads to workarounds, frustration, stress, and then it can also put your patients at risk because if your machine's down, if the machine is down, of course, there's a workaround for that, right? There's alternative things that you can use. But what if I've taken a blood sample or I've used some kind of point of care testing machine, and then it's not really transmitting to the main hub where the physician could see it on his desktop somewhere. So now you'll have a user actually manually hand scribing the number, which leads to risk because they could transpose the numbers. So in the case of some medicines, 2.13 is a lot different for medical management than 2.31. And so, we have to think about when we're adding devices into healthcare, we have to make it so that it's a seamless process, which is not always the case, but seamless with the touch of the interoperability, and then also that it actually adds value to the clinician and not just to the business operations.
Yeah, I think that was a great explanation of how technology can help different stakeholders, but it can't just be one-sided. Otherwise, the other loses out big time. And I think this is relevant to, something you touched on earlier. So, widespread challenge for providers is balancing this use of digital health and practicing traditional medicine. So, according to a study conducted by the Journal of the American Medical Informatics Association, nearly 70% of physicians who use EHR technology during care delivery face stress due to the demands of this health IT that we've been talking about. So I assume there's a similar stat for nurses as well. So from your time as a practicing clinician, can you talk about this burnout and, just maybe give us a little story of, how you felt and dealt with this dual-edged sword?
Yeah, sure. So as a clinician, I think we enter healthcare with an idea that we're coming to, be a resource to help people. But then, as we've noticed over time, and especially with COVID being in the pandemic and things of that nature, that there are these unaccounted for costs that healthcare providers are taking on. So when you ask me about burnout, yeah, I've definitely suffered from burnout. My burnout came from moral distress way before the pandemic, actually. So I can't even imagine what my colleagues are going through right now, day in and day out. My situation was, it stemmed from a lack of staff, equipment, and really the items that I needed to actually take care of my patients the way that they deserve, to the level of quality that they needed. So for me, it wasn't so much of a technology thing, really. But when you go back to what you said about physicians and nurses, overall, when you talk about digital health, EMRs has been noticed as the number one cause. I mean, outside of patient care issues, because you got to think about it. EMRs were essentially created as a billing and reimbursement platform. It wasn't really made for clinical documentation. And so now, as you see the switch from fee for service, which is getting paid on how much stuff you do, to a model of value-based care. You know what that means for clinicians and nurses, for physicians and nurses? That means now that they're going to be required to add even more clinical documentation per patient per visit, just to be able to meet those quality standards. How does this impact the workflow? Well, you take your typical PCP visit. You go, you see a doctor 15, 30 minutes. It already feels like a time crunch from the patient's perspective and experience, as well as the doctor. He's got 15, 30 minutes to really get your story, get some orders, and get out of there. So now, could you imagine what that impact is going to be now that there's even more documentation that they have to capture? For some people, it might take them 15, 20 minutes just to open up about the social determinants of health, which are extra things that may or may not be impacting the way that they're able to care for them independently. On top of that, I know a lot of physicians who have gotten into medicine because they truly wanted to care for a patient. They didn't necessarily want to lug around a computer. We hear from patients all the time that technology becomes a physical barrier for the interaction. I mean, even if you're having lunch, socially distanced, and you have your phone in front of you, it becomes a physical barrier. I want my experience to be meaningful. I want you to look me in the eye. I want to know that you're paying attention. I might have to share something with you that's really kind of like either embarrassing or maybe really important. And so all these things are at play inside the environment during that one little small sliver of time that you get to see a patient, especially if it's an annual visit or maybe it's some kind of follow-up. And so all of this, I say all of this to say, clinician burnout is real. I mean, we like to look at it like, oh, it's just the physicians, but it's the physicians, it's the nurses, it's the respiratory therapists. It's just pretty much everybody in healthcare right now they're at this point where they're just frayed. They're just frayed, and not afraid, but like frayed nerves, and we've got to do something about it, very definitely. So in creating digital products, can we also include, our clinician folks? Can we really think about how something's going to impact our workflow? And I would hope for the future that maybe that we can start to even redesign EMRs in a way that supports clinical documentation, but also kind of embraces that patient as a central aspect for a good experience.
Yeah, that sounds like a lot mixed into one. I think, especially through your experiences, I'm sure you've, felt a lot of different, emotions, and physically had to do a lot of things that are outside of your quote unquote job description. And, I visited a PCP recently too, and I noticed, the majority of conversation was probably only like a few minutes, and there was more time of just, him looking down at his Microsoft Surface and, scrambling to get all my vitals and stuff noted down. So definitely understand and have experienced that as well. But now let's look to a solution. I mean, there are, ways. We have amazing technologies, we have great clinicians. So how can we, put them together and, possibly use something like design thinking to come up with some sort of way to alleviate this provider burnout?
Yeah. Design thinking is my favorite. I mean, it's the platform for innovation, right? And it's so easy. I mean, anybody can use it for anything that they want to create, whether they're solving for a software problem, hardware problem, a process improvement problem. I mean, design thinking is just great. So if you get a chance, definitely try to get yourself some resources or speak to another nurse innovator about what that is. Inside of design thinking, there's this famous term, and it's called how might we? So I'm going to ask you, how might we, redesign that EMR in a way that actually creates that value-based model of care? How might we get technology companies and product companies to actually come on the chat, actually include, be more inclusive with who you include at the product development design space? How about we actually include more nurses in that development? Or, as it is in Lean Six Sigma, it's called Gemba. It's great if you stand outside the problem and just think, oh, this would be really great. Wouldn't it be great if this clinician had something XYZ? But until you actually Gemba, which is follow the clinician in their day-to-day, you really can't understand the impact of what it is that you're developing. you have this great machine, but there's one, and it's like 2 departments over. So that wasting time and energy of actually having to retrieve it and locate it, this all plays into the workflow. So, I mean, when you think about design thinking, I would say those would be my top 3. EMR, including your nurses and your clinicians, and getting these tech and product companies to just kind of bring us in, because we know the industry and we know what it's like to work in these spaces.
Agreed. I think it's about time we take an interdisciplinary lens to everything. And I think, being at Northeastern as well, from my time here, even though I'm on the health sciences track, I'm still weaving in a lot of these business and analytics components and seeing that this is kind of the future. So these are just a couple of examples, but I totally agree. I think, Jordan's even mentioned it in the chat, but inclusivity is definitely the way to go forward. So I guess kind of bouncing off of this idea of coming up with some sort of solution. So as we integrate technology, there are ripples and there are challenges. There's often a lot of friction between clinicians and those rolling out the technology. So how can we maybe use human capital or some sort of existing frameworks within these healthcare settings to essentially lessen this burnout as we try to bring in more and more technology at the point of care?
Sure. So I think, if we can, so right now nursing and healthcare as a whole is very task heavy. I think if we can delegate some of those tasks to other ancillary staff, that may help. What does that mean? That means maybe utilizing our other healthcare partners to the full extent of their training and their licensure. So we have LPNs, CMAs, or that certified medical assistant. You have licensed social workers, care coordinators, care navigators. You have, case managers. All of these different people can actually kind of take up some of the weight from other areas of healthcare and still allow us to do our main thing and support the patient at the same time. I think one innovative thing, and it seems simple, but I often ask myself, why don't physician offices use like clinical documentation specialists? Like why in the ER do they provide scribes for the physician so the physician can be one-on-one with the patient and just really be tuned in? And as he's doing his exam, the scribe is, taking down the information. Why don't they use those in physician offices? If it's a matter of the cost of employment, why don't we create some kind of employer resource share group? Maybe one doctor doesn't have to bear the whole cost of that employee, but maybe if you have a practice with 4, maybe they can come in on, 4 ways and help enhance that situation. So, I mean, these are the things that I think about, like how can we really use people who are already out there looking, they've had the training, let's put them in play. Let's share the work, let's share the love.
Yeah, it seems like this uneven balance where we have some individuals that, they're not fully tapped into in terms of their potential, like you just mentioned, and then we're pushing others to their maximum. So now we need to kind of find some sort of middle ground, as we start to harness these technologies more. So we've kind of touched upon, the challenges with data and technology and care delivery. So can you, I guess, kind of wrap up this, section of, ideas with some of the ways that data is used to improve healthcare outcomes and patient care? Maybe just a couple examples, that are really the main ones that we look to.
Sure. So currently, when you think about like AI, which is artificial intelligence, machine learning, that it's a key player in a lot of the things going forward with healthcare. And for AI to even be successful, AI needs at least 1 billion data points just to be able to train itself and be really efficient. So why is this important? A lot of hospital systems, EMRs, software, and digital health tools, they use or they will begin to create clinical decision support. That means that if a patient arrives with a certain clinical diagnosis, that the software may pair that or analyze that and say, hey, listen, for this certain class of patient, for this category, for this diabetic type with these types of things, these might be the specific interventions you may want to consider. And so AI is like super, super exciting. Like it's exciting. Like, can I have a geek? Like, can I have my little nerd moment? It's exciting because, I mean, you think about like collaborations and partnerships. So Salesforce, right? They're a CRM company. They are usually like very big in like sales and retail and consumerism. Well, guess what? They, I see you, Jordan. So Salesforce just really did a partnership with IBM, who, you know, of course, did a lot of clinical work with Watson and healthcare data. So you can see that partnership being really cool. Salesforce already has an AI component. It's called Einstein, but it's better for that, like I said, that sales stuff. So now when you compare these two giants together, man, can you imagine the types of things that can happen? You have software, you have the clinical data, you have AI, things are going great. AI is also very useful in radiology. You know, you have just computers that just work endlessly to like scan different records and images to find and detect and create these patterns that says, you know, if we see this little spot right here in so many records and it's tied to this diagnosis, maybe we should start to learn or maybe present to the physician that, you know, maybe your eye didn't see it, but we noticed this little spot, or this spot has changed from this micro nanometer to something else. And so I'm really, really kind of excited about that. And I wanted to actually get on my soapbox about why AI will never replace the physician, because I know there's a lot of fears out there. So case in point, there's a machine out there. It's an eye machine. It's a machine. It scans your eye, scans your retina. Really important for the diabetic community. They should get their eyes checked, you know, every year. And what it's looking for is it's looking for one specific condition, and it's looking for diabetic retinopathy, which is the leading cause of blindness in diabetics because of sugar levels and things like that. So this machine, what it does is it takes a picture of the retina and it actually sends it, it transmits it, right? Little wiggly lines to the ophthalmologist who has to read it. At the end of the day, you're always going to need a professional, clinically licensed professional to be able to interpret the films. So is it going to replace a physician? No, but most likely this machine is already in use in rural communities where there is no physician. There may not have ophthalmologists on service, and it's a good way to just kind of scoop up that population that may be at risk for being neglected, right, by using software. So that's what I'm excited about.
I appreciate that. We love soapbox moments. Those are always good. Yeah, I mean, I think AI is definitely powerful, and I think AI has a lot of just potential in terms of crunching this data well, compared to any other technology that we've seen in the past. In the chat, Carmen has talked a little bit about AI bias into data, and I think that's another thing. I've had a focus on health equity throughout my academic and professional career thus far, and I'm sure you can touch on the fact that when we look at all this data, we have to make sure it's culturally and linguistically competent, with all of the diverse populations that we have.
Yeah.
Is there anything you want to add as we kind of pivot away from this AI technology conversation?
Yeah, so I want to kind of piggyback. I've been looking at the every once in a while you'll see me like look away, and I'm kind of looking at it like a second screen, and I'm checking the chat and everything. So, I mean, there's two big themes I see going on in the chat right now: AI bias, and what did Jordan put? Something just along the lines of just algorithms, right? So what I want to say about AI algorithms and bias is when we continue, like all of us continue to redefine what healthcare looks like in the future, I think that we have to definitely become inclusive, much more inclusive. I mean, you even think about right now with trials and such, which is something that's really gotten spotlighted in a major way. Most of the participants are just straight white males. I mean, even white women are included in clinical trials and research at a rate that's higher than minorities. So when you look at like the general population and 40% of the overall population identifies as a racial or ethnic minority group, but yet you only have 5% of the participants maybe Black, or 1% maybe Latino. You know, how can we really say that we're really developing equitable drug discovery or medical devices when we haven't even included people in the overall research? AI algorithms, as we continue to go forth and use software to, you know, accelerate things and do really cool things, we have to use data in a way that looks at data to say, okay, here's the data. It's showing us that there's inequalities and disparities. Are we going to do something about it? We need to now target those inequalities instead of saying, wow, you know, it's really interesting. We see that there's this whole population that's really, really, you know, vulnerable and suffering, and do nothing about it. AI algorithms, we need diversity. I get on this another soapbox moment. We need diversity in healthcare because we need to be at the table to develop AI algorithms. We need to be able to give our input into how the AI is going to read, respond, and present the data, so that we can have equity for, you know, for everybody. And we definitely need to make some improvements. You know, is everyone is saying equity for everyone lofty? Will I see it in my, you know, my time here on this earth? I don't know, but we definitely can grow by leaps and bounds. I'm hopeful. I'm hopeful.
Yeah, me too. I think we have, you know, always dealt with these equity issues, but I think the first step is acknowledging them, and we see them in the spotlight. And I guess we're kind of jumping ahead because we're going to touch more about that a little bit later. But now we can take a brief pause again, just to give Rhonda a break from her soapbox. And if anybody wants to chime in and ask a question or two, feel free to do so through the chat, or, you know, unmute yourself.
Yeah, I would love to hear from you guys.
Well, I'll ask a question. Hello, it's fascinating listening to you and your perspective around healthcare and where it can go. I am fascinated because I'm also a nurse and a case manager. And I am really, I love your perception around diversity as we create, or as algorithms are created to help with population health. And I wanted to give you that feedback. I hadn't heard that, and I look forward to incorporating that in whatever I do in the future. My question is less forward thinking and more around the here and now, and just kind of gauging current population health needs. And I know it's not as exciting as AI and all that potential in the next 5 to 7 years, but I work in a health system where, you know, we want to be able to project what our patients are going to need in the next year or two. And I'm wondering where, like, you know, as a student, I'm curious to know what methods are being employed or what's worked. And thank you.
Oh, well, thank you. And thank you also for bringing forth that, you know, some of the feedback and like the comments and all. So I'm going to go out on a limb here to just say that these are my thoughts, right? I don't represent any kind of organization or association with this response, but I will tell you that in population health, which is actually dear to my heart, I spoke about being in case management. I love population health because I think the premise of population health is, how do we meet that one person's need, right, individually, to make them better. So what I've seen with some larger companies is that they will employ AI as almost like a prediction of, and it's a part of data science. It's like some really brilliant mathematical formulas and coding and things like that, that can take current situations that people are going through and then project either the development of maybe another ER encounter, or maybe the decline of a condition. So there's that in play. I think, you know, there's like big players like the Blues, and there's Aetna and people of that magnitude that may be using some of that information right now just to try to, you know, help the case managers to outreach the right people at the right time, because that's important too. You can have a great solution, but you don't have it available at the right time. At that point, is it the right thing? Have we done the right thing for our patients? Have they received the right thing? You know, so I think about that. Can you give me another point about your population health? Like, did I answer that for you? I think you're on mute, Deborah. Sorry.
Sorry, thanks. No, I assume AI is finding its way into our health system. I'm up here in Maine, and I'm assuming that it's it's embedding itself, but at the same time, needing a billion data pieces, it's going to take a little while. And I know interoperability isn't really scheduled to phase in until 2025. We've with coming out of COVID, we'll have some health needs. We've got a changing demographic up here. And it really would be, I think, it would be nice to be able to project a little bit again in the near future, what the health system, I'm sure the leadership is already 10 years ahead of me, but if I were to bring anything back to my department, I wonder what that would be. So I'm just kind of throwing out a question, nothing in particular.
Sure. In health systems, what's most commonly found is you'll see they could be a part of a collaborative collective, which is redundant, right? Collaborative collective, but they are part of a data sharing partnership. So if you're in an area that may not have a lot of resources, they may be able to tap into like the Mayo Clinic or something like a Cleveland Clinic or something like that, just to kind of say, to either leverage their technologies or provide insight on how you're dealing with a certain population. So, I mean, even if your data system, even if your health system doesn't have access to like giant databases and data sets, there's still a way that you can just enhance what you're already doing. We don't have to create a rocket to go to space, but we just have to do like a little bit better and then so much better in what we're doing now. Thank you.
Yeah, thank you for that question, Deborah. That was really good. So I think we're ready to move on. And then we can, for anybody else who might have had some questions or you're still brewing, we can get to those at the end of the session. So now let's talk a little bit about the future of data in healthcare. So we've talked about solutions, challenges, what is data? We've kind of touched a bunch of bases here. But how can we take our use of data in healthcare to the, quote unquote, next level? And what is your definition of next level?
The next level. Okay. So, I mean, I think we already touched on this, and that's just improving patient outcomes for all people, right? Using clinical analytics to be more targeted or more focused in on making changes where changes are needed, So what does that look like? That looks like more data integration. That looks like maybe from a technical standpoint, more cloud-based software apps or solutions that provide us with that full view of the patient. I think it also looks at how is the health system, how is the hospital and health systems taking care of the providers of care? Because it's great. We can do all this really fancy stuff. We can build another tower, put another 300 beds down if we want. But if we're not taking care of the people who actually have to provide care, then it's all for naught, because people are going to continue to leave. People are going to be continually discouraged. And let's be real, crabby healthcare workers don't lead to good patient outcomes or experiences. And it's tough to be a healthcare person who wants to just kind of be in it and give your all, but you're just kind of inundated with so many different external pressures. So next level, data, cloud, but you have to take care of your people too. You can't, and that means more than maybe just a slice of pizza for Nurses Week, which is coming up, by the way. Nurses Week is coming up soon. So, but that's what I have. It's like pulling together all the solutions to make healthcare work better.
Yeah, I'm totally with you on that one. And I don't think I've ever, heard that as one of the main answers that someone's given in terms of next level. But, as you've touched on, we're not at the point where technology can just replace humans. So we although some might think so. So it's very important to take care of our, frontline workers. And, thank you to all the nurses on the call as well. And thank you to you, Rhonda, and anybody on the front lines, because, that service is just extraordinary and such a sacrifice for our healthcare system and everyone's well-being. So moving on, we did touch upon this a little bit earlier, which is this whole component of inclusion and health equity. So health equity has been an ongoing issue that, as I mentioned, has plagued the healthcare system ever since its conception. And now we see, disparities in healthcare under the spotlight with specifically this COVID-19 pandemic, whether it's, vaccine equity or it's, just certain populations getting the virus more than others. So how can we use data, in this time when we're going through a major, once in a lifetime kind of pandemic to make sure, that everyone is being taken care of at somewhat of an equitable level?
Yeah. So I feel like there's challenges in the question itself, because you asked, how can we use data? Well, how can we use data if data is not collected? Right? Like, what if there are certain agencies in the United States that either stop collecting data or stop reporting data or stop disclosing data, so we need the fullness of data to actually be able to see what it is that we're looking at so that we can apply the right interventions where interventions are needed. COVID most certainly has, you said, spotlighted or highlighted healthcare inequalities. I think it's made it even more obvious that there were these, subset of people who just weren't getting what they needed anyway. And so now you put something on top of it, something external pressure where the whole system is just, under pressure. It leads to like a greater gap for those individuals. So when you look at COVID, I mean, we've been through a lot. We are going to continue to learn a lot, but I think it just goes back to we have to get the data and then we have to act on the data. We can't just look at it. We have to use the data to just target those populations and target the things that are meaningful. And unfortunately, I say fortunately, unfortunately, I say unfortunately because I've studied social determinants of health for a long time. And sometimes I think its reception is that it's not, I don't want to say it's not really important, because it is very much important. But I think that because certain entities may be very focused on how do we convert our interventions into profits, and maybe this might not be profitable, therein lies the problem. You have to think about who is in charge and who is it that can make things happen. So data, we got to grab it, but then we have to do something about it. And I'm telling you, it's not fair to just look and say that, African Americans are dying at so many more, times a rate than other groups, or certain groups are just neglected altogether. If you perceive it and you recognize it, you've got to do something about it.
Yeah, I think you brought up some really good points there. I think, as you mentioned, it starts with just the equitable collection of data. And then it's, the next piece, which is actually piecing together some sort of solution that can cater to all. So I guess touching on that, have you seen some sort of, technology adoption challenges that have kind of come up with this surge in data use?
So yeah, I would say yeah. I mean, even as we here presently, as we've survived 2020, we see two things. One, we see that people are now more likely or feel a little bit better about engaging with technology, because at one point we were all in the house and that's what we had. But even when you think about tech adoption, I still see a lot of hesitancy, because here's the question. This is almost to one of the points inside the chat as I pull it up right now, is getting back to that question about mental health and sharing data. The concern is, who owns the data? How are they going to use it? And will this data be used against me? And I think there's a lot There's a lot to be built out yet about trust and transparency, about who's collecting your data, who owns it. Do I, the patient, own it? Does the health system own it? Does some, do they have the right to sell it? To whom, for what reason? Can they disclose it to law enforcement? And for what reason, and things of that nature. So we really, for data use and collection to be really successful, we really have to kind of get back into that building trust and transparency.
Yeah, that's spot on. I think that's totally accurate. And I think one of the important things that we have to consider is, how our demographics are shifting. So, right now we see that there are 46 million Americans that are 65 plus. But as we get to 2050, that number is supposed to balloon to 90. So, if you think about that, that's tremendous. And this kind of growth of a certain population hasn't really happened in modern history. So I guess going back to this adoption piece, we see a lot of digital tools coming out, but at the same time, there's this digital divide forming between populations that have access to technology and those who have higher tech literacy and those that don't. So, where are we going wrong here? What's the issue, and how can we kind of get at this that's a little bit more deeply rooted?
Sure. So to your point, and even in the pandemic, as we see an increased use of tech and tech adoption, people generally, I read some statistics last month that said people who are 65 years and older, even though they've used technology as a secondary gain to accomplish something, whether it's communicate with their doctor or FaceTime their children or things like that, you have to understand this was a generation that did not grow up with technology glued to their hand. So adoption becomes an issue for them for a couple of reasons. One, concerns about privacy, use, lack of training, maintenance and upgrading. I mean, I've got an iPhone, and between this and the iPad, every other week, it seems like I've got to update something or secure something or change something out. But with the 65 and older crowd, even though they use technology to some degree, they've only used it 50% of the time, like at a usage rate of 50%. And that's smartphones and tablets. So as you develop products, you have to really understand who your consumer is. Just because you come out with something that's really cool, if they don't see use in it, what's the point? You got to think about cost too. I didn't see anybody bring up anything about wearables yet either. But when you think, oh, I have an Apple Watch, and this one has a Fitbit, that might not be in everybody's price range. They may live in an area where internet is not stable or high speed. They may not use the internet. They may not have access to it. Or to your point about health literacy, how can I, as a patient, participate in any kind of health promotion or health activities if English is not my first language, right? How are we delivering to them? What if, I have a questionable, what if I'm undocumented? What are my thoughts and fears around needing to go to a hospital? Is it equitable? Or will something happen to me? So there's like a lot of things to really kind of think about that. But I will tell you this, when you design and you think about the problem that you're trying to solve for, make it really simple. Just because, like for case in point, I'm in Atlanta, big city, but you go 15 minutes down the road, somebody might not have stable internet. So as you're developing these point of care devices or software, maybe leverage Internet of Things, right? Maybe think about, how can I put this on a cellular platform? How can I build this with equity in mind, with the person in the center? So that's what I think.
Yeah, those are great insights. I think Brad actually in the chat mentioned this component of having some trouble setting up simple technologies like video conferencing and just setting up internet-based solutions that we might think are simple because we just have it on our phone or have such easy access to Wi-Fi or LTE, whatever that might be.
Sure.
So I guess in that vein, then you would think that some of these large health systems might swallow up these little rural health hospitals or healthcare centers, whatever they might be, and then say, okay, hey, we have this great telemedicine option. Why don't you guys use that? Because it's better than maybe driving hundreds of miles to go see a PCP. But then there's that huge divide again, right, which between administration, management, and the actual patient. So where's the reconciliation there, and how can you kind of meet a middle ground where healthcare systems are served well, but also these underserved folks?
Yeah. So that was like the primary reason why I got my MBA, because I truly believe that we can do patient quality, like we can give patients quality care and make a profit at the same time. Now, to what degree that profit is, does it need to be 300%? Maybe not. Maybe we need to, back it down a little bit so that we can actually pour back into the people that we're actually serving. But I think when it goes back to your point, and something I mentioned earlier is, you have to put health equity in the center, because what you focus on, becomes the thing, the driving force for all your, your production. I mean, we hear it 1,000 times in nursing leadership meetings. What gets measured? How's that go? It's what gets measured gets improved, or something. It's something cliche that I just, I heard time and time again, but it's true. I mean, I really hate to say it, but I think what has to happen, like to avoid a greater digital divide and increase health equity, is that we have to build digital health products in a way that democratizes healthcare and really kind of, brings in that equity. I mean, I just hate to keep saying it, but it's literally the thing that we need to move forward.
And that's so ironic, right? That we,
Thank you, Jordan.
think that, when we think of population health, why would we ever think about data or machine learning, AI, or any of that? But it always comes back to how, our healthcare system is so intersectional, and every, piece just has some sort of connection to another. And it all comes down to that individual patient coming into, that private practice or that hospital, just looking for an answer or some sort of positive health outcome from their experience.
Sure.
So yeah, I think this is, a great point to kind of wrap up on. So is there anything else that you want to add, Rhonda, before we, open it back up to questions for about our last 10 to 15 minutes?
Yeah, so I know we covered a lot of stuff, and it's funny because even though I'm a nurse that works on a software team, I'm not very, like, my role is not very technical, but I do have to understand how some of the technical aspects play into the development of the software. Because at the end of the day, what we create has to go into the hands of an APC, a nurse practitioner, or physician, so that they can do their best work. And so, all things said, I think as like nurses, nurse leaders, entrepreneurs, device, even life science students like yourself, we have to think about, as we launch forward in these different things, you've got to ask yourself 3 big questions. The first one is, whose interests are you serving? Is it the patient, the provider, the physician, the hospital, or the insurer? Because who's likely to benefit from what it is that you're trying to do? The second thing I think you have to do is you got to include those members of the actual population. So we have to get people who are, we have to get representation of our actual population in these conversations, at the design table, in focus groups and things like that. How can that happen if so to your internet point, how can I be a part of a clinical research trial if I don't have high-speed internet and I never see the little ad on my browser when I go to Google, right? How is that possible? How are we working to get those people in? And then lastly, and this is the big one, you're developing things, solutions. The number one question is, who's going to pay for it? Who's going to pay for it? Is it going to end up being, a patient responsibility? Is that price point in a place where, I really want this thing? I think it would be great, but maybe insurance doesn't cover it and I have to come out of pocket. Am I willing to pay $500 for something that I might just need for six weeks? So those are the things. Whose interest, who's at the table, and who's going to pay for it? And if you can answer those questions, I think you're golden.
Wow, yeah. I've never heard it summed up so well, but I think you really just did that. So thank you for that. I think that's a great way to end, and some great takeaway thoughts, especially as we all, interact with data, no matter what our professional job title might be. So thank you again, Rhonda, for all those insights. And now what we're going to do is open it up to anyone that wants to chime in and ask questions that they either couldn't get to or that have come up throughout the session. And again, feel free to use the chat or just unmute yourself.
Yeah, so I have a question. This is something I just thought of while I was kind of listening to the lectures, and this is kind of about redundancy of data and kind of systems talking between each other. Because at least in my experience that I've had in healthcare systems, one is, especially when like you're moving to a new area or a new healthcare system, they have no real way of getting your documents or electronic health records in any way that seems efficient or really kind of like that shows that they're really talking to other systems or parts of the world. And also like with the use of like paper data and doubling up with electronic health records and using paper almost every time that a patient comes in to kind of just put in the same data every time. So I was wondering if you guys could speak a little bit onto that or where you're thinking go in the future.
Yeah, so redundancy is definitely a big issue, specifically, like you said, as health systems continue to combine or become acquired, merge, share data and things like that. That also leads to, physician burnout, as well as a component of physician burnout, and also it erodes the patient experience and the whole encounter. Something you said, I'm taking notes here. Something you said about using paper charts, and I'm sorry, I don't know who was it that was speaking. I couldn't find the unmuted.
Me, Tanner.
Oh, hi, Tanner. Okay, I see you down there. One of the things that I wanted to say, the University of Pennsylvania did something really nifty with paper charts. And so what happens with patients who may often get genetic testing was the University of Pennsylvania didn't have a way to kind of absorb or ingest the data from a secondary vendor or a lab or something like that. So what they did was they used like a PDF, right, by Adobe, which is considered, anytime you scan information in, it's considered as unstructured data. It's paper with words on it. And so what they did was they actually enhanced their EMR to be able to scan through the different words and maybe look for different sections and have the system scan the paper, pick up the words, and present it and store it in another section of the EMR. It's kind of like so it's a good way to kind of work on a temporary solution. It's a Band-Aid is what we say. It's a Band-Aid for the need for a larger integration of interoperability so that one system can talk directly to the other and it can go on. The challenge is and I don't know if you were on earlier, is if it's in the mapping. So if one software picks up A, B, and C, and another software picks up A, B, and D, what has to happen is there's a manual mapping with the software teams that has to say, okay, this spot here and this spot here, it's kind of like databases, right? This in SQL, this space and this space, they mean the same. So we have to, connect them. And unfortunately, sometimes there's a loss of data because if this software has some information that doesn't have a location for this one, by the time we merge the two, there's really not a home for this one to go. So as we continue to see the merger and acquisitions of physicians' practices, very definitely, and then hospital systems, here in Georgia, we've seen tremendous amount of that. That's going to be an issue. Redundancy, that's where data cleaning comes into, which is its own thing. I saw somebody in the chat asked about that. You also have to transform data. There's a whole lot of stuff that goes on in the data management section that I didn't touch on. But these are processes. These are technical costs that have to be, absorbed by the purchaser to be able to get that clean and complete record. And, in some cases that might not be beneficial for a health system, but you really got to think like, is this going to help my provider? And that should be, a part of the component in the decision.
Do you think there should be some kind of national standard for the way that data is handled and stored?
Man, Tana, you are the man right now. I love it. So one of the things that I wanted to bring up, but I didn't for the sake of time, is the use of a unique patient identifier. There are places like, I think the UK and the NHS they may use this, and essentially what it is it's a standardized location of information. It's not really a database, but it's an identifier. So it's something that doesn't change. It's not something as it's not like Rhonda Manns, right? It's not even like a social security number, but it's really just like a bunch of letters and numbers that can be used so that if at any point this one person goes to any health system or touches the healthcare system at any point of care, that all their records would be complete and be under there. In the US, we've tried to start it, but it kind of like stopped for a little bit. I know there's a coalition right now that's trying to use it. Or try to start their own little company, which is actually cool because they found a way to produce this patient identifier, but then also grant the user, like the patient, access levels. Like I can take back my access. I can hide this part. I can share only this part for the doctor and this part for a family. So I think very definitely we need to maybe start moving in that direction. The thought of maybe having one unified electronic health record or database storage, I don't think I don't see that happening anytime soon, for the fact that you have to figure out who is going to collect the data, who's going to be in charge of it. Is it the government? Is it a private entity? There's so much unanswered tidbits to it that it's just, I don't see how that's going to work. But if we can move towards that patient identifier, man, that would make data integration and just absorption and ingestion so much easier. Because at the end of the day, we need to get that data before the providers so that the providers can do treatments and interventions and things like that. So really excited.
Thank you.
Thanks.
Yeah, thanks, Tanner. That was a great question. And now we'll go back to Martina, who has a question about the software that you're developing at the company that you work for. So if you want to take that away.
So I can't speak on that. I can't, it wouldn't be fair. I know, I love it. Like I can't speak on that. But I will tell you this, is that I work, again, with the software development team that builds essentially EMRs for the clinicians to go and see and take the clinical documentation for the patients. Now, in that, I've learned there's a lot in software development. You have to, you have the interface, you have like the user part where, you put in the information, but in the back end, you have to think when the user presses print, how do you capture that data? And then what format should it be? And how do you send it to the printer? And how does it go to the cloud? And how do you store it? How do you retrieve it from the repository? And then how long do you keep the data? And who do you share it to? The doctor's view is a lot different than a nurse's view, or maybe like the billing view. And then how do you send it to reimbursement? So it's really fun. I mean, we can, Martina, we can talk, offline if you have anything specific, but in the general sense, it's amazing innovations are going on every day. And I'm not even kidding, like every day. It's so exciting and rewarding to be that nurse that sits on the team that says, but what about this? Can we do this? Hey, can we get rid of that? Can we put a checkbox right there? It's so exciting. And I would encourage more nurses, if you're interested, definitely try to find your way into an area of healthcare that brings you passion and joy and lights up your fire every day.
Yeah, wonderful. Thank you. Yeah, there was a disclaimer there if it's not confidential. So I was expecting kind of like that you may not be able to reveal much, but thank you.
You're welcome. You're welcome.
Yeah, great. Thank you for that. And then on to Cynthia. So what are your thoughts about the practicality of incorporating lay health people like community health workers in digital health design and delivery to bridge the gaps in sociocultural support?
100%. Let's do it. I mean, it's a win-win situation because, community health workers, if we can get closer, here's the overall answer is, if we can get closer to the problem, then the better solution we can develop. So when you talk about, bridging the gaps in social cultural support, I know Philadelphia is doing something now where they're trying to take lay people and training them as doulas for maternal health medicine, not medicine, but maternal health support and things of that nature. It's really a win-win situation because you're now creating an employment structure for people with skills to now do a thing. They're actually providing to meet the needs of a population that, needs the thing. So yeah, let's do it. I mean, and that will also offset some of the pressure back on the primary care physicians and stuff like that. The key in the design, though, is you have to think, once they collect that information and they get the demographics, the social determinants of health, you know, how are they going to communicate that? How are they going to communicate that back to the doctor's office? And who do they speak to? Do they, you know, do they report back to insurer? Do they report back to the primary or the specialist? There's a lot that has to be involved, but it's not impossible. It's out there. You just find a successful model, just replicate it, you know, copy, paste.
Awesome. Yeah, great insights. Again, thank you, Rhonda. And I guess we have just about 2 more minutes. So if anybody has one last thought or question, feel free to throw it out there. If not, we will wrap it up.
And I just want to say thank you before we all do head out. Thank you to Rhonda and Nirban and everyone for your participation and this really important discussion on data and the use of data, the complexities of the systems that are gathering the data and the impact it has on our healthcare. And I appreciate the participation, and our next session is April 6th, and we'll be focused on legal issues as healthcare goes digital, and then we'll wrap it up with one more session on April 20th. So we're really excited about this. We welcome your input even after this. If you have any questions, you can use me as a conduit. My name is associated with all the registrations, so feel free to reach out. If you want to get involved at all with Northeastern and our healthcare entrepreneurship program, welcome that as well. So once again, thank you, Rhonda, so much, and Nirban, and I wish everyone a great evening.
Thanks, guys. It's been great.
Thank you.